Hi, this is Dr. Nick Biasotto, your host to the podcast of the Medical Society of Delaware, Delaware Healthcare Reality. Just to let you know, we have three big events coming up for the Medical Society of Delaware. On October 18th, the Superhero for Hope 5K Health Fair and Food Drive will occur at Rockford Park. Keep that in mind. On October 23rd, as part of MSD's annual meeting week, a virtual CME program with this year's theme, The Body Connected Healthcare Wearables, will occur. And don't miss the 236th annual meeting of the Council session on October 25th with keynote speaker Stephen K. Klosko, MD, MBA, author and former president of Thomas Jefferson University, who will present Swifty, Startups, and the Singularity. For details for all of the three events, go to the MSD website at www.medicalsocietyofdelaware.org. That is, again, www.medicalsocietyofdelaware.org.
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Nick Biasotto, the host of the Medical Societies of Delaware's podcast, Delaware Healthcare Reality. And today we have a guest, a neurologist, who's been on our show now for the record time of 3. He's been on our show 3 times, and that's Dr. Bob Varipapa. Dr. Varipapa is a well-known neurologist in Delaware, and he practices in Dover. His credentials have already been mentioned earlier in the podcast, so if you've listened to the early ones, you know all about him. But today he's going to speak to us about dementia. Dementia, one of those things that everybody comes to my office and says, am I demented because I'm starting to forget where I put my keys, etc.? And so you have to go through a whole series of questions to see if it's just everything we all do. I've missed my keys many times. I put them there. I don't know where I put them. And I don't think I'm demented. I don't think so, Bob. Do you think I'm demented? No.
We could check you out.
But there are various types of dementia. And what we're going to go through is the various types. And I think, maybe what is the distinguishing factor between them, and then signs and symptoms to make you lead to the fact that the patient should be evaluated further, as well as testing for dementia. So, Bob, tell me a little bit about dementia, the definition of it, and some of the types that we have.
So we're getting more and more referrals with patients with complaints of dementia, especially over the last 5 or 10 years. It seems like our practice has skyrocketed in the number of patients that we're seeing with this condition. And part of it's probably due to the aging of the population, which I think plays a big part in it. There are quite a few different types of dementia. The most common one is labeled senile dementia of the Alzheimer's type, or Alzheimer's disease. And other types include vascular dementia, Lewy body dementia, frontotemporal dementia. There's mixed types of dementia. And there's some less common ones like normal pressure hydrocephalus and dementia related to head injury, like chronic traumatic encephalopathy that you may have heard about with the football players, for instance. But most of them most likely have Alzheimer's disease, or vascular are probably the two most common.
Okay. I also read in my studies that there's Parkinson's dementia, as well as Huntington's dementia.
So dementia can be related to Parkinson's disease and Huntington's disease and other neurodegenerative disorders. There's a dementia called Lewy body dementia, which has Parkinsonian features. And the way to think about Lewy body dementia versus Parkinson's dementia is that in a Parkinson's patient, they'll start having motor problems like slowness of movement and tremor and stiffness, difficulty walking first, and then usually years later they'll start having memory and cognitive problems. So that tends to be a Parkinson's dementia, whereas a person with Lewy body dementia will have cognitive issues, usually fluctuating cognitive function, some psychological issues sometimes, hallucinations, and then later on they'll start having Parkinson's symptoms. So the Parkinson's symptoms become comes second,
To
whereas Parkinson's dementia, the Parkinson's symptoms occur first.
tell me a little bit about Alzheimer's disease.
So Alzheimer's disease is the most common one that we see, and I think the thing that we see most affected with Alzheimer's disease is memory, short-term memory. So a patient becomes more and more forgetful. One of the tests that we use to help diagnose Alzheimer's disease is called the Montreal Cognitive Assessment. And part of the test is memory function. And invariably, the patients with Alzheimer's disease will typically have forgetfulness, and there's 5 words they have to remember. They're given those at the beginning of the test, and then towards the end of the test, they're asked to repeat them. And invariably, the patients with Alzheimer's disease have trouble with the recall of the 5 objects.
Okay. Okay. How about the, we hear about the Lewy body. We hear about the frontotemporal because there's a couple stars that had it. Lewy body, I think it was Robin Williams. And the frontotemporal was
Bruce Willis.
Bruce Willis. Tell me a little bit about them, particularly the frontotemporal at this point.
So the frontotemporal dementias are classified into 2 types. There's the behavioral type, and then there's the primary progressive aphasia type. So in the behavioral type, frontotemporal dementia will start with behavioral issues, and the patient will be undressing themselves, doing inappropriate things. And the interesting thing is there's a lot of, the memory isn't so much affected in the beginning. It's really more the behavioral things, and then the memory comes in later. And then in the primary progressive aphasia type of frontotemporal dementia, you see loss of speech, word-finding difficulties, sometimes difficulty with swallowing. So it's more oral mouth kind of illness, so to speak. That will then progress into more memory and cognitive issues.
But that affects Broca areas more than that's in
the speech centers of the.
Okay. Can you distinguish the others from the typical ones we just talked about, the more common ones? I mean, my point is this: is when a patient comes to me and says, I think my wife tells me I should be checked for dementia. I can't seem to remember things that I've just done. What are some of the symptoms that say, I think you should be checked out further?
So obviously, as you know, history is probably the most important part of the medical examination. So we'll want to get history not only from the patient, but even maybe more importantly from family members, from spouse or
a lot of them bring their families in.
Sometimes they do, sometimes they don't. Mm-hmm. And the ones that don't are the ones you worry about. But we'll look for short-term memory issues. The spouse have to repeat themselves over and over again. Is the person just forgetful? They had an appointment or they were supposed to do something. Sometimes they'll have, as it gets more severe, they'll lose recognition of people. They won't know who their grandkid is, for instance. And that's more of an Alzheimer's type picture. If it's more of a Lewy body type of presentation, you may have variability. That one day the spouse is fine, no problem, and the next minute they're all over the place and completely out of it. So when you see that fluctuation in cognitive function and behavior, then that could be Lewy body. And then Lewy body eventually goes into the Parkinson's symptoms over a period of time. And then with frontotemporal, it tends to be more really behavioral. And those frontotemporal is probably the most difficult dementia to treat because it does not respond to medications very well. And you have a family member that a lot of times is beside themselves, that they have this spouse, for instance, or loved one that's acting completely inappropriate and completely uncontrollable. And the person has no real awareness of that they're acting inappropriate. So it's very difficult to treat those
How about
types.
aggression? Which one's more prone to become aggressive?
Well, I think the frontotemporal tend to be more problematic in that sense, but any of them, as they get more severe, can cause aggression. And what I tell patients is a lot of times the dementia will bring out the person's dominant personality type. So a lot of times with dementia, people lose their inhibitions. So, for instance, you may get angry at somebody, but you'll hold it in and you won't say anything because you don't want to create problems. With a patient with dementia, that anger is just going to come out.
Okay.
If they're mad at something, you're going to hear about it because
No
they don't
inhibition.
have any inhibitions. And so what I tell people is if a person was a little bit paranoid in their younger years, they're going to become more paranoid. If the person was kind of agitated, aggressive person, they tend to be more agitated and aggressive. If the person was controlling, they become more controlling. Likewise, we have some patients that were very happy-go-lucky. They tend to be more happy, so they're very pleasant patients to have. They'll come in and they're smiling, and any problem? No, I'm not having any problem. They don't know which way is up or down, but they're happy, which is good, and I think easier for the families to deal with the patients with that kind of presentation.
How about a person who's been to your office 50 times and gets lost one time coming in? That's an issue I see a couple.
Are you
not
asking
a lot,
if that means that they're developing dementia?
Could it be a sign of dementia?
So I think certainly changes in performance of learned activities, whether it's driving a car, getting lost, not knowing how to operate the sewing machine, whatever, certainly can be a sign of dementia. It could be a sign of other illnesses too. Maybe their blood sugar's going down.
True.
Maybe their blood pressure's going up and they're having a little encephalopathy from that. So you have to certainly look at other issues for sure.
It's a growing problem in our country as we age, because our age, as you mentioned earlier, is as we get older and older and we live longer. These things can happen, especially vascular dementia. Yes, as we get older, our little arteries get plugged up and things happen, correct?
So vascular dementia is also one of the common dementias, and some people have mixed dementia where they have an element of Alzheimer's disease and an element of vascular dementia. And we can discern that actually a lot easier now with some of the new testing we have. One of the nice things about vascular dementia, if you could really get the patient aggressively to treat their risk factors, you may slow or stop the progression of the disease. So a lot of patients will come in, their blood pressure is not controlled, their diabetes is not controlled, their cholesterol's off the wall, they're not exercising, living kind of a typical, quote, American life, so to speak. And so if we can get those people to aggressively treat some of the risk factors for vascular disease, then you could slow or stop the progression.
Okay. How many a week do you see of dementia patients? Just give me a rough ballpark.
I'd say how many a day? I probably
a day, huh?
I see probably 10 patients a day with dementia. It's probably one of the most common things I'm seeing now. And when I've been in practice for 40 years, and when the first 10, 20 years of practice, it was not a majority of dementia, but it clearly is now.
And that's an aging process, you think?
I think it's an aging process. It's probably also an awareness process, because I think the whole issue of dementia is now more at the forefront and people recognize it more, and so people are brought in for an evaluation where in the past they may not have been.
Up here in northern Delaware, I don't know about southern, but we have a center called the Swank Center that whenever I feel as a patient should be studied further from my preliminary questioning, I send them there and they do quite a good job of testing, and they give me an idea how advanced and or if they have dementia. So I use that quite a bit. But what testing do I do as a primary care doctor in my office and simply say, do this and let me see how you do it? Is there something as a primary care doc I can put to the patient besides the Montreal cognitive testing? Is there something else?
So maybe I should just tell you kind of what our paradigm is for evaluating these people. The first thing we do is obviously take a good history and try to get an idea or a flavor of which way the person's going. We'll do cognitive assessment. We do the MoCA or the Montreal Cognitive Assessment. We also do computerized cognitive assessment, and we try to correlate the two and see if they match up.
What's computerized? Tell me about that.
There's a test where a patient can just sit at a computer with a keyboard and press a couple buttons. They're asked questions on the screen, so to speak.
Gotcha.
And then the computer will spit out some data as to
whether
the patient has, whether they have attention issues, whether they have memory issues, whether they have executive function issues. So it kind of gives us a little bit more detailed assessment of what's going on. And then, if the suspicion for Alzheimer's disease is there, then one of the things that's just come up in the last year are the biomarkers. And so there's a test called the phosphorylated tau 217, and there's also the
Lumipulse, it's called.
Well, I'm going to tell you about that in a minute.
Okay.
And then there's another test called the beta amyloid 4042. So these tests have been out for about a year now, and we've been using them extensively. Just recently, the FDA approved a proprietary brand of these tests. And I kind of get a kick out of it because I said, this is the first time this has been available, but we've been using these tests for the last year.
I have not.
But because a pharmaceutical company now has come out with this and will start marketing it, it'll probably be used even more. My big question is whether the branded one is 4 times more expensive than the generic one that we've been using over the last year.
Probably, but this is strictly for Alzheimer's dementia, correct?
Yes. It's
Okay.
very sensitive for the diagnosis.
Do you think it's going to be cheaper than the PET scan to determine amyloid in the brain?
Well, it's not only cheaper, but it's easier to do, and it's much more available. It's just simple blood tests. So you can write an order for this, and the patient can go to LabCorp, Quest, or a hospital and get it drawn, and you'll have an answer within a week.
Gotcha.
Whereas a PET scan, may take a couple weeks to get scheduled,
and it's more expensive, I'm
and
sure.
you're talking a couple $1,000s.
Yeah.
And so I don't usually do PET scans unless we have other issues that we're dealing with.
Okay. All right, so now we've nailed the diagnosis of Alzheimer's disease in the patient. We have the Lumipulse, as it's called, the tau 217, beta amyloid 1-42, whatever it is. It's
beta amyloid 42/40.
You got it. Now we know they have it. We have some monoclonal antibodies that are available for usage. Are they effective?
So we're getting into the treatment phase of the discussion, and what we do for treatment, our primary drug to start with is one of the anticholinesterase inhibitor drugs because they're very easy to use, they're inexpensive, well tolerated, and they work well in about 50% of people. If a patient has mild dementia, meaning a MoCA score of maybe 22 or higher, they could be a candidate for one of these new drugs, lecanemab or donanemab. These drugs are relatively new. The studies, in my mind, are not as great as I'd like them to be. They don't cure the disease. They don't stop the progression of the disease.
Then what good are they?
Well, let me finish.
Okay.
They do slow the progression of the disease and may result in a modest improvement, but it's not really felt to be a dramatic improvement. The improvement is felt to be more dramatic in the less severe patients than the more severe patients. But I think again, it's one of these. It's one of these drugs that the pharmaceutical companies have come out with, and they're going to market the hell out of it. It's very expensive, and so there's going to be you have the whole medical industrial complex behind this pushing these drugs. But if you look at there's some editorials by some well-known neurologists who kind of question, well, is it really as good as they're saying it should be? And the jury, I think the jury's out. We'll have to see.
Have you used them?
I have not personally used them. We usually refer people because the other problem with these drugs is that they're modestly effective at best. They don't stop the progression of disease, but they do slow it. But they're troublesome. There's a high rate of side effects. So 30% of patients have side effects, including brain edema or swelling of the brain, bleeding in the brain. Usually the bleeding is not catastrophic, but who wants to have bleeding in their brain?
Correct.
They're troublesome to give because they require an IV infusion every 2 to 4 weeks. You have to get serial MRI scans to monitor these people. So it's a lot of work and a lot of money. The cost is about $25,000, $30,000 a year just for the medicine, not including the monitoring. So it's a very expensive drug, very troublesome drug, lots of side effects for some benefit maybe. So I'm not like 100% on board with these drugs, but I'm curious to see, maybe with some experience over the next year or two, maybe some further study, we'll have a better idea as to how well they really work. These drugs are based on what's called the amyloid theory of Alzheimer's disease, thinking that this amyloid buildup is what's causing the dementia. And so the drugs basically reduce the amount of amyloid in the brain. The problem is that as dementia progresses, you're losing brain cells. And the drugs don't bring back the brain cells.
Right.
And probably the cure for Alzheimer's disease is not going to be to so-called cure it once it occurs. The cure is to prevent it from starting in the beginning. So you have to figure out how can we prevent cell death. Because if you start losing brain cells, we all joke that you don't know how many brain cells you have, idiot. But if you lose brain cells, things don't work as well. So if you could prevent that loss of brain cells, then that's going to be the holy grail, so to speak.
If you stop.
These changes for Alzheimer's disease can occur 10, 20 years before you show any signs of it. So a person who comes with Alzheimer's disease at age 75 or 80 probably started having that disease when they were 60 or 65. So that's when you have to treat it, when they're 60 or 65.
Well, if you could stop cell death, which is a cell death, you discover something that can make you live a lot longer in general, stopping cell death.
Well, then we get into the whole issue of longevity, which is a whole other topic.
Okay, gotcha.
We could have a podcast about that.
It's very interesting. So I would be hesitant to use these monoclonal antibodies because they're expensive, number one. They don't cure the disease, and they don't stop the disease, but they may slow the progress. Now, that's only if you get it on an early stage. Say when they're 65 and they're starting to show things like that.
So if you could, I think that's why if you're going to believe in these drugs, you have to also believe in early diagnosis.
Mm-hmm.
And that's where the biomarkers are very nice, because if you have a patient that comes in, we classify patients who have memory loss as either mild cognitive impairment, which basically means that they're clearly having some memory or cognitive difficulties, but they're still functioning very well at home, versus Alzheimer's disease or dementia is when they're not doing things at home the way they should. They're messing up, they're leaving out ingredients when they make the cheesecake, or they're forgetful and spouse has to remind them over and over again. So if it starts affecting their activity of daily living, then it's called dementia. But if they're functioning well, we call it mild cognitive impairment. You want to catch these people when they're in the mild cognitive impairment phase or even before. So if you get a patient that comes in and says, well, I'm having some memory problems, perfect person to consider doing one of the biomarker tests.
Got it.
Because if the biomarker comes back positive for Alzheimer's, that's the person you probably want to give treatment to. You don't want to give... Treatment's probably a lot less effective if someone has a score of 20 and they're not functioning well at home and they're having personality and behavioral issues. It's not going to work as well in that type of person.
I gotcha. Well, I'm taking away from this that the Montreal Cognitive Assessment is a good way to get started in your office to figure this out.
It's an easy test to administer. You can get an assistant or a nurse to do it.
They're not doing spinal taps anymore, are they?
No. I mean, you could get the same information now with the blood test, so I don't think there's any reason to put somebody through a spinal tap for this.
Gotcha. Okay. Anything else you want to bring up about dementia?
I think the only thing I just wanted to reinforce, as you know, I'm retiring from practice, and our practice is actually closing in Delaware, in Dover, and there's going to be a big shortage of neurology, and there's going to be a big shortage of people taking care of patients with dementia, and we have been sending a lot of our patients to the Swank Memory Clinic, which is part of Christiana,
right?
And the nice thing about Swank is that they have been certified by Medicare and government to be in what's called the GUIDE program. So the GUIDE program is this multidisciplinary program where a patient comes into the program. They have to be over age 60. They are given a navigator, a care navigator, to sort of guide them through the process and make sure things don't get lost. They have social service support, nutritional support, home support, a 24-hour helpline. So they're given a lot more resources to these patients, and they're also in a situation where they can offer the patient these new medications, lecanemab and donanemab, where it requires more of an effort. You have to get PET scan done, you have to get serial MRI scans done. They have to be set up for an IV infusion. So the GUIDE program and the SWANK program, I think, are highly recommended. I hope we don't swamp them with so many patients that they won't be able to handle them.
Well, so far, so good. I've been sending them and getting good results from the SWANK Center. I'm pleased with it. I have a couple patients right now, I've had them over the years, that have amyloidosis. Are they more prone to getting Alzheimer's disease or not? Because the ones I've had, none of them show signs of dementia.
I think it's more of a peripheral amyloidosis.
Yes, correct.
So I think it's a different type of amyloid.
Amyloid.
But
Never thought it was that important in my younger years.
Nasty stuff.
Yeah. Okay, so let me take away from this that Montreal Cognitive Assessment's a good thing. The Swank Center may take the patient and lead them, help them out through their course of the disease. You can get some blood tests now if you suspect Alzheimer's disease. It won't come up positive for frontotemporal or mixed or Lewy body or any of those, correct?
Correct.
Only for Alzheimer's disease. And the testing is available, and then you can let the Swank Center help you out.
So I think, from a primary care doctor standpoint, if someone comes in with memory and cognitive issues, you can either refer them right out, or if you want to take a greater role, do the Montreal Cognitive Assessment, consider doing the biomarkers, maybe do some other testing, like we usually like to check thyroid and
sure, you want to rule out other things, yeah.
And if those point in one direction, if the biomarker comes back positive, then you got to go to the Swank Clinic. If all those tests are normal, it could be psychiatric, because like some patients with severe depression can have memory or cognitive difficulties. But there's no reason a primary care doctor can't do the initial evaluation and then triage the patient appropriately depending on the results that they get.
Fully agree. Oh, very good discussion. Anything else you want to add?
I think we covered everything fairly well. The only thing I would add is I do have a nice, longer, detailed outline of a lot of the stuff on my webpage. So if people want to go to deldoc.com/links, deldoc.com/links, there's a link there, and they can pull up. It's about a 12-page document that has all kinds of information that might be helpful.
Well, Bob, interesting. And I'll tell you, Bob sends me links all the time regarding this book or that book. You got to read this thing. You got to read that. Very well read, very intelligent individual. Sorry to hear you're retiring. Well, maybe for your sake it's good, but I'm sorry to hear you're retiring. And I wish you well.
Thank you.
Okay. This is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. If you have any questions, concerns, or comments, or suggestions, please contact us on our email, healthcare.reality@medsocdel.org. That's medsocdel.org. And as always, thanks so much for listening.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.